Hey, what's up, everyone? Welcome back to Basically EMS. Got Wade and Kylee with me today, so we got the OG crew. We are going to be talking about spinal injuries today, so back on a trauma subject. So, as always, let's kind of jump first into the spinal anatomy. We'll talk a little bit about that. Really important for you guys to remember the breakdown for the different sections of the spine, the different vertebrae and the counts. I don't know if you guys had that experience, but I feel like it's a pretty common National Registry question. Mm-hmm. So if you haven't taken your registry, that's a common thing you'll see pop up on
the numbers.
Tests. Yeah. How many for the thoracic and whatever, right?
I would say, honestly, just kind of generally, this is no different with this topic, but like anything anatomy, you want to know this stuff so well that those feel like gimme questions, and this is no different.
Yeah,
that's a good point.
It's kind of nice for questions that are so simple and objective. Like this is black and white. You don't need to put any thought into it. Like here's a number, know the number. So if you don't know this and you're going to be taking your National Registry soon or something, go take the time, learn these numbers, and then you should hopefully have that for National Registry. So starting at the top, we're going to have the cervical spine. And so there's going to be 7 cervical vertebrae. We'll jump a little bit more specifically into that here in a second. There's some specific ones there to talk about. And then there's going to be 12 in the thoracic spine. And there's going to be 5 in the lumbar spine, 5 in the sacrum or the sacral section of the spine, and then 4 down in the coccyx. And so that's kind of your tailbone. And those are going to be fused. So it says 4, but if you look kind of at like a diagram in the anatomy, it looks kind of just one piece, but it's 4 fused vertebrae.
Well, and remember, it's supposed to be, for the most part with kids, unfused. It fuses as they get older. And it makes sense because kids fall on their butts when they're trying to walk and stuff. So it has to be, it has to be, as in, like, that's the best solution is that their coccyx is not fused when they're a kid. And then, like it normally does, it just fuses and matures as you become an adult. But also not every adult has a fused coccyx either. So, yeah. It's not, you're not going to know that, but obviously you're not going to, but it's kind of one of those cool little variants that they find on x-rays and stuff. And they're like, oh, this actually kind of helped you.
So what you're saying is Wade shouldn't go around and poke people to see if they have a fused coccyx.
No, that's for the Paramedics and Pints podcast. That's not for this one. Anyway, sorry. I just
lawsuits are just paper, right?
Yeah. As long as you're not the one writing the check, for sure.
Right.
So coming down, a couple to talk specifically about that you might hear is going to be C1 and C2. And so C1 is called the Atlas. And that's based off of, if you know mythology, Atlas, he holds the world on his shoulders, right? And so, there's the famous statue of him kind of kneeling down. And so the head is kind of like the world that the Atlas is holding on its shoulders. So C1 is going to be called the Atlas, and then C2 is the axis. And so that allows our side-to-side movement, like we're saying no, essentially. So that's how we have that capability that we don't have so much in the rest of our spine to do that turn is going to be that C2 vertebrae.
One more that I want to add that's not on this list is the vertebral prominence. So if you feel your neck, there's that one big vertebrae that's like the most forthcoming. The reason I want to bring it up is because it ranges. Most people think it's going to be like C7. The last of my cervical, that's going to be the hump on the back of my neck, right? It's actually can range anywhere C6 to T1, and more so from like a step-off perspective. So if you're feeling down their neck and you're like, oh, that should be higher or that should be lower, just keep in mind it can vary a little bit. So that way you're not, assigning an injury to something that might not exist.
Mm-hmm. Yeah, I would caution anybody from being like, oh, they have a C3 whatever. They have a cervical step-off or something.
Yeah. Right.
It's up in the neck.
At least for your differential stuff in your head.
Yeah.
And I've been doing this, I think, since I went through EMT school, but it's how you remember the numbers. It doesn't apply to all of them, but it's breakfast at 7, lunch at 12, dinner at 5.
Oh, that's nice.
And I can't for the life of me think of something that ties in 5 for sacral, 4 for coccygeal. I'm like, personally for me, it was like the whole 4 snacks a day or something like that kind of helped for like the coccyx, but I can't think of anything. So if you think of something or you have something, let me know so I could pass it off, or us know so we can pass it off to other people, but that helps me. Breakfast at 7, lunch at 12, dinner at 5.
I usually just remember like 7, 12, 5, 5, 4. If I could just say that over and over in my head, it's just, that's how I burned it in.
Mm-hmm.
Sure. Yeah.
It's not a great way, but.
Yeah, and if you're watching or listening and you've got any good ways, like throw them in the comments too for other people that might be watching.
Mm-hmm.
There's so many cool little memory tricks. We don't know I'm sure we don't even know 3% of them, right? Like we know such a small percentage. So we always love to hear that stuff to pass off to the next people. So coming down, talking about the actual vertebrae itself, and if you have the ability to kind of pull up a picture, it can kind of help you to visualize this. But the front part's going to have a round, solid block of bone called the vertebral body. Okay, that the back part is going to have kind of that bony arch. So again, it's kind of hard to talk about it, just talk about it, right? But it makes more sense when you kind of have a look at a vertebrae. You can find diagrams of vertebrae and everything. And inside of that arch is going to be the tunnel called the spinal canal, and the spinal canal is where the spinal cord is going to live. Okay, so because we need to remember that's kind of the purpose of the spine, not to give us shape, right, so we can stand up erect, but also to protect the spinal cord as it runs down, so that we can have nerves that connect the brain to our extremities. So that's going to run through that spinal canal there, and then vertebrae are going to be connected by some ligaments, and then there's also vertebral discs that kind of cushion in between. So you might see some people that have slip discs. That's going to be an issue with those vertebral discs, so those can kind of break down and cause issues there. So it's really not super complex, the anatomy of the spine. If we're talking about the bone portion of it, the spinal cord a little bit more. So so not too much to remember, other than thinking about the fact that the spinal cord is living inside of that spinal canal, and then remembering those different numbers.
I think of the intervertebral discs as jelly donuts, and I'll expand on that in a little bit as to why I do that. But like, if you think about something soft between two bony prominences, think about what happens if we overflex one way or the other, and I'll explain a little bit as we kind of progress. But
yeah, the little airbags to cushion and everything.
I was going to say the intervertebral disc, so it's made of hyaline cartilage, which is the toughest cartilage in your body, which makes sense. So, I mean, those discs are quite stable for everyone except, excuse me, anyone who lifts, like lifts for work or us. If you're a cop, paramedic, firefighter, UPS worker, whatever, ours aren't stable because they just slip. And it usually has to do something with what you're doing movement-wise, but inherently those are very stable. That hyaline cartilage is tough. It's super tough, so it's usually because there's a structural problem, like you are turning inappropriately or something that actually causes problems with the disc. The discs themselves usually seldomly have problems.
So if you're new to EMS, go learn how to lift and get strong. That's a big thing for long-term career longevity is like if you can go deadlift once a week and like try to actually move some heavy weight, deadlifting and rowing and all that stuff, and really building that back and shoulder strength up,
if it's
huge.
appropriate for you.
If you can. But
people are out there deadlifting and stuff that should not be deadlifting, and that's why they they herniated it.
Well, yeah, do it correctly.
Right.
Yes.
Well, just keep in mind too is like you're not dealing with the average 200-pound adult all the time, right? We deal with the heavies sometimes, and it helps.
Yeah.
I'm sorry, I just love the way you said that. Heavies.
Well, I mean,
like you were visiting another place there.
Yeah.
That's what it sounds like before you start dissociating.
I'm just a regular heavy. That's why I like heavies. I got to distinct myself a little bit.
Kylee, you want to talk about the spinal cord?
Yeah. So, all right. So the spinal cord is essentially an extension of the brainstem. Really, the only difference is the foramen magnum is the anatomical feature that separates the brainstem from the spinal cord. And I tell my students that all the time. The foramen magnum comes up on every single test ever, like National Registry, EMT school tests, whatever you're doing. The foramen magnum is the base of your skull that essentially kind of delineates, as far as my brain works, the spinal cord from the brainstem.
Well, and anytime we're talking foramen, it just means a hole in a bone, an organic hole in the bone, like so veins and arteries and nerves. So
and magnum is large.
Yes.
Yeah, big hole.
Yeah.
Bingo.
So that I think is important to remember because the essentially structure of that is going to be the same thing throughout your spinal cord. And also, I can't remember exactly what it is. You guys might remember, but the spinal cord actually terminates at is it like T10 or T12? A lot of people don't realize that. And again, like Chris was saying, if you have a textbook that you can refer to, If you look at the picture of the spinal nerves, it'll show you the cauda equina, which is at the base. And it's a very complex system of nerves, and that's responsible for your sex organs, your GI organs, your lower extremity innervation, you name it. But if you look at it, the actual bundle terminates somewhere around like T something. But do you know what I mean?
Yeah. I can think of the image, and it's higher than the sacrum.
Yes, it's higher than like the level of the lumbar region that I think a lot of people are aware
I
of.
want to say it innervates around the L3. Don't quote.
I think it's
that.
a little higher. It's like L1, L2.
Is it? Yeah, it's somewhere towards like the end of the T or thoracic spine and beginning of lumbar. But so that is interesting too, because again, if you look at that picture, that cauda equina which is horse's saddle, right?
Horsetail.
Horsetail. Oh, I've been saying it wrong. I've been saying horse's saddle.
Nope, horsetail.
You got the horse right.
Yeah, well,
You're halfway there.
at least I got part of it right. So I mean, it's if you think about it, it makes sense, right? Because it does. It makes so much more sense than the saddle. Well, I assumed it was saddle because like you sit in that area, like your pelvic floor and like all that kind of stuff, which it's all important stuff. But that makes so much more sense because it does look like a horse's tail. So, but anyways, back to the anatomy. I always tell people that the actual, if you look at them, like the brainstem versus the spinal cord, they look identical as far as the white matter and the gray matter. White matter just means it's myelinated. It has fatty layers around it to help speed up conduction. White matter is what usually has to do with our higher level functioning. And then your gray matter is unmyelinated it's unmyelinated, I believe is the term, correct? You might hear about those in like the medical things as well for like myelinating disorders, I believe is what they're called, things like that. That's what they're talking about. They're talking about white matter versus gray matter and the fatty sheaths around that. Those are called the myelin sheath.
Yeah, and the gray and white matter, I recently learned this, is actually composed of cholesterol, quite a bit of cholesterol. It's just, your brain is just a sack of fat essentially that controls you. You are a fat sack that controls your meat body. That's exactly what it is.
Well, it is. It's just goo, right? Yeah. And it's suspended in a quite delicate, pressurized cavity. So.
I'm going to remember that next time I'm eating like something with high cholesterol. I'll be like, Wade said it's good.
Yeah. So, but
Wade said I can.
If you think about it too, though, like one of the number one things you can do for brain health or brain health, neurological system health in general is fatty acids. Every doctor will tell you that. I think pretty much every study ever could tell you that. So it makes sense because those fatty acids actually help speed up conduction. So when you have nerves like sensory nerves and, motor nerves and things like that for reflexes, you need to have quicker conduction. So those layers, also there are layers around the brainstem, the spinal cord, and it's the same meninges as the brain. That's also nice because it doesn't change. So if you learn it, the order of the meninges for the brain is the same as with the spinal cord. And this is something I see people miss all the time. Is knowing the order of them as far as like superficial to deep or the deep to superficial. So that's something you'll probably see a lot of in your national registry questions too. Am I missing anything as far as the anatomy goes?
Not really. I think kind of like you were saying, I see people miss the meninges questions a lot. And so working our way in, just I think how I remember it, right, is if you know the orders from inside out or outside in, your preference, right? But the way I always thought about it is, right, it's dura, arachnoid, pia. Dura, arachnoid, pia. Dura is the most superficial because we want the most durable layer to be available, right? We want that to protect us. Arachnoid kind of sits in the middle, and it's named, if you look at the space, arachnoid spiders, looks like webs, right? Where the CSF flows. But then pia, now this is a weird one, bear with me. Pia is a small word. You got to protect the small words, so we keep it really deep inside.
I like that, though.
That's how I always remembered it, and it was yet to lead me astray.
So your meninges are like a Russian nesting doll, kind of.
Yeah.
Pia is the smallest, so it's and on the inside.
Yeah,
See,
exactly.
It's funny that you say that because I think if you look at the drawings, like how the pia extends into the sulci of the brain, which are just the grooves, I, in my EMT school notes, wrote pia in the little tiny grooves because I thought pia small, like that, and that's what I think of every time. So it's pia, and then the next one, like it just fits into those little tiny grooves, and then the next, which they're not that tiny, they're actually very large, but that's how I remember it. So pia means small, dura means tough,
And remember, the better you know those layers, and this is diverting away from spine injuries, right? But like you'll know the bleed layers too. If you know the meningeal layers, you can figure out subdural, epidural, arachnoid, whatever, right? Just make sure you spend time in the anatomy, because once again, we want anatomy to be gimme questions.
Yeah. So actually, speaking of the CSF, excuse me, CSF resides in the arachnoid space. I think if you, again, this is probably one of the best lectures to reference a picture with, but the arachnoid space, it's, if you look at it, I think I've seen, I don't know what image it was or whatever, but it was like a close-up of the arachnoid space, and that's exactly what it looks like. It's just a bunch of like fibers almost. And
like spider webs connecting the top and bottoms.
yeah, and there's blood vessels in there, and there's CSF in there. So, and again, like Wade was saying, that's important to remember for not only your brain bleeds for trauma cases, but medical cases as well. Because subarachnoid bleeds standardly, in the case of trauma, can present with, differences between your epidural versus subdural bleeds. So,
yeah. I had a little experience. My mom ended up having a subarachnoid bleed like 4 years ago. She got in a car wreck. And fortunately for her, she ended up having 0 deficits out of it. But that's kind of an uncommon thing I'm hearing with the arachnoid space, just because it's so central. So yeah, just keep that in mind, right? Like once again, the layers are going to help you with the bleeds, and you're going to know what's where.
well, and if I remember correctly, you guys might remember a little bit more about this, but with the subarachnoids, they have higher, or they're not the highest, but they're on the higher end because of the pressure with the CSF. Right? Like the potential for pressure increase because of CSF in that area.
Introducing blood as an irritant to an area it shouldn't be. And on top of it, we're introducing a fluid that's taking up more space than what we have to give.
Right. Okay.
Yep.
Yeah. So, and then again, remember if you add the prefixes to it, epidural, epi means above the dura, right? Subdural means below the dura, arachnoid, obviously. And then I don't think there's nothing specific. Are there even? That's probably kind of silly to ask out loud, but anything for the PIA?
I mean, I feel like
There's gotta be
subarachnoid and epipia would be essentially the same thing, right?
Even subdural could be under the PIA, but I think that might fall more into that like intracerebral bleeding.
Yeah.
starts
Okay.
showing
That's.
up.
I was gonna say I don't think I've heard anything about that. So it's just primarily the epidural, subdural, subarachnoids.
I think that, I mean, I could be wrong, but I could also see a subdural being under that, because subdural is like as a term is really broad. It's just below the dura, could be anywhere. I think that might be another distinction as well.
Yeah. The last thing with CSF that, excuse me, I was just going to mention is if you do have CSF leak, the potential for CSF leakage with basilar skull fractures in particular, you might see it coming out of the ears and then the nose. I've never done halo sign or the halo sign test or whatever. Have you guys?
I've tested for it, but I've never found them.
Yeah, I can only remember testing for it once, and it was like a skater kid that smashed his head pretty good and was bleeding out of the ears, but it was negative.
I did it for a concussion on a rollover, same thing.
I saw it in my ICU rotations, and that's it. But like in the field, I never had the.
Yeah, that's fair. One other thing with CSF too is remember, like as a function, right? It's got a few different ones, but it's where we regulate pH. But as far as like trauma goes, CSF is our buffer. That is our fluid cushion. That way, I'm not, oh my goodness. I'm sure we're not going to talk about like coup contra coup injuries in this moment. That's more head injury stuff. But it's along the same pathway, right? Because CSF goes all the way down your spinal canal, but it's that buffer. We want to stop our brain from slamming into our skull. Same thing. We don't want our spinal cord up against those vertebrae, because it doesn't take much, right? It was like, I mean, I remember in medic school it being described as much as like an overstretch, a nick, a twist of the spinal cord, and just the wrong spot is enough for lifelong deficit. So we want that cushioning layer throughout the entire spine as well.
Yeah, and for everybody too, we have a head injuries podcast. So if you haven't checked that out, and we're talking about some stuff, we're being specific about spinal injuries, but that would be a good complement to this one to check that one out as well.
Especially when, again, the whole reason we got onto that was because the spinal cord has layers, just like the meninges of the spinal cord are the same that you see in the brain. So that was the whole point of that. But just want to reiterate as well what Wade, I think, just said about CSF being throughout the total of the spinal cord. So that's going to come up when we talk about like secondary injuries. I think we talk about it a little bit, but secondary injuries with spinal cords, CSF is one of the big culprits for that. So we're going to do spinal nerves next, unless you guys have anything to add.
hit it.
Good segue.
I actually I have this weird relationship with these. I love them and I hate them. The cranial nerves I don't like, I think. Do you guys on Old
them.
Olympus Towering, top of Finn and German View?
I have one, but I don't.
Oh, it's not appropriate.
I don't know if it's.
It's probably not appropriate. I think I know exactly what it is.
You won't forget it though.
Just go look it up. I'm sure it's
Yes.
pretty easy to find.
Yes, you can find all that.
Honestly, for me, the cranial nerves was like learning the capitals in high school. I learned it in paramedic school, and then I know like the vagus nerve, and that's all I really remembered afterwards.
So. I got burned into my head in my anatomy and phys class in college, and then I had an instructor who just would not let it go, and since then it's.
I had a chiropractor he was a great anatomy and physiology teacher, but he was super crazy about the cranial nerves.
Same. He was a chiropractor. He was also, he referenced, this is unrelated, but my professor referenced like, yeah, you would kill someone this way if you slipped a knife here. And I'm like, after like the fourth example, it's like,
what's in your closet?
What do you know, dog?
It's like kind of the whole approach of like the more information you give, the less or the more unassuming you are, right?
Yeah.
That's how a lot of serial killers get. No, it wasn't me, but I'd be happy to go do my fingerprints. Of course. Yeah. See. Anyways. So the 12 cranial nerves, 31 spinal nerves. The spinal nerves come out at the nerve root area. If you think about that, that's just the base of it. So those extend out into your spinal nerves. They innervate everything in the peripheral nervous system. Those 31 pairs of spinal nerves innervate and give information for. Your cranial nerves are everything from your neck up. Well, I guess chin. No.
Your vagus goes down to your heart, actually.
Yeah, and then the accessory is right here.
Yeah, it usually ends at the trap.
For the most part, your cranial nerves are everything up here. For the most part, your spinal nerves you can kind of consider kind of like the same idea as, I guess, the foramen magnum.
Yeah.
Just thinking about it conceptually.
And the cranial nerves also do have individual functions. There's some that's like for taste. There's some for eye blinking. There's some for turning your eyes left and right, or like these little, accessory muscles in your eyes. So it's a pretty complex intervention thing or innervation thing. So if that's something you're interested in, spend time in it, dive into it, because you're going to need to rote memorize. There's not a lot of good ways, unfortunately.
I don't think that's something that's generally tested at the basic level, but at the higher levels, you're probably going to have to know your cranial nerves because you'll get tested on them.
In medic school,
I was going to say, we had to learn them in medic school. The cranial nerves specifically, the spinal nerves, no. And not as far as I know, unless you're going to physical therapy school.
I know in med school, they are expecting you to know like every innervation of the brachial plexus. Like you need to know exactly which nerve does what and where, but that's way above our pay grade.
Yes, which is actually, the next point being the phrenic nerve and like the other things. Because really here we're talking about the spinal nerves. Cranial nerves might be a little bit more specific for like strokes or, I guess even for your head injury patients as well. If you're doing like a maybe really in-depth neuro assessment, I don't know. Spinal cord injuries would be the good application in this case, obviously. But if you don't know a head-to-toe assessment for the spinal nerves, that's okay. There are a few things that like CMS we check for in our trauma assessments. So if you don't know these exactly, it's totally fine. But it is helpful to know there's 12 cranial nerves and there's 31 spinal nerves.
Mm-hmm. One thing I do want to talk about, and I might be cutting into you a little bit, Kylie, here, but like with the motor and sensory, right? So remember our nerves have a couple of functions depending on the nerves, right? The 31 pairs, there's sensory and motor. So the way I think about it is sensory is the environment's information to us. Motor is our interaction with the environment, right? So where we live, it's cold right now. I walk outside in the morning in a t-shirt and my skin says, hey, it's cold. Sends it to my brain. My brain says, hey, it's cold. Motor nerve, let's go get a coat, right? So like, remember these innervate and work together as well. We don't want just one or the other. We have them for purposes.
Yeah, well, and that's actually just a good point for kind of a similar concept to how reflex arcs work. A lot of people don't realize that reflex arcs actually happen at the level of the spinal cord, and it has to do directly with the amount of receptors that are being stimulated simultaneously. So, and I use this as my example, like if I grab onto my arm like this, or someone grabs onto me like this, or, I grab onto a hot stove or something like that, like that or touch it. The point being, there's a large number of receptors in this area receiving stimulus. This hurts. So in this case, probably baroreceptors, a ton of them would be going off. And in that case, the information would go from the sensory nerves to the level of your spinal cord. Enough stimulus would basically prompt your spinal cord to take over and stimulate those motor nerves to take over so that you create the action. Classic example, you touch a hot burner, that area of your hand is not only irritated because the number of receptors that are being stimulated, but also the damage to that area. So that information goes to your spinal cord, it reflexes back, turns right around to the motor nerves, you pull your hand back. That's how the sensory and motor nerves work together, like Wade was saying, but also with the reflex arc.
Yeah, and just to make sure, like, because the last thing you want is like, my hand's in a fire. Processing. Brain says your hand's in a fire. You should pull that out, right? We don't have that long to give.
Yeah. With those two, again, they've just got different jobs. Each reflex has a different job. That's a reflex specifically. This is just a stimulus.
Do you want to talk a little more about the phrenic nerve?
Yeah, so I'm actually, if you guys have anything to add with the phrenic nerve, I'm probably a little less educated on it.
So the phrenic nerve is the one that controls our diaphragm, and it's a big portion of our breathing, right? If we don't have diaphragm contraction, we don't have breath. So that phrenic nerve, which I believe we have it right here, C3 to 5, right? C3, C4, C5. If there is damage to those anywhere the cord in that place, we're starting to enter necessary to life functions, right? Including breathing, pulse rate, blood pressure, just brain STEMmy things. But with that phrenic nerve, if we have damage there, likely that patient is not going to be able to breathe because their internal communication system has been snipped, right? So that's where we've got to get ahead of, like, yes, as much as we want the patient to breathe on their own, we got to get ahead of it and do what we can do to control that. So BVM, rescue breaths, that kind of stuff.
Yeah, that's the big thing for like high cervical injuries, is just looking for respiratory and making sure that we don't need to ventilate, because that happens. People that fall off a high place onto their neck can die just essentially from suffocation because they sever they sever their spinal cord in that area, and the phrenic nerve gets damaged, and so they're not able to contract their diaphragm, and so they're not able to breathe anymore. So we need to keep an eye out for that to make sure that we can manage that if that's the situation.
Yeah. And always, it's going to be tough too, because like C3, 4, and 5, those are pretty high up there on the neck. So, we're going to have to put a collar on this person more than likely, depending on mechanism for sure. And so that could impede depending on what kind of collar you're using. If it's one of those where you don't have the window to the neck, you're going to have to kind of trust your gut. But there's a reason we start ABC, and that's a big one.
Yeah, well, that saying for the C345 keeps the diaphragm alive, or keeps the lungs alive, or whatever your phrase is. C345 keeps the diaphragm alive. Is what I always remember.
Yeah. Now, as far as different types of injury to the spine, it's pretty broad, right? Now, you can even go even further, but the first one we'll talk about is compression, right? So I think the telltale example is, and we've all seen it, 3-foot side of the pool, the no diving sign, right? That's that someone dives into something head first, they crack the top of their head, and then
Swan dive.
Bingo, right?
Yep.
Comes straight down, and that force transfers. And you can have a compression fracture the other way too, of like someone jumping off of a 3rd-story building, right? And they land straight-legged, and not only is they're going to have some lower extremity damage, I would wager, but they can compress through those lumbar as well, right? And so that's going to send the force up. A lot of it just has to do with the way that it travels down. Okay, so forces that compress the patient's vertebral body can cause herniation of discs, subsequent compression on the spinal cord and nerve roots. We can also have fragmentation. There was one I remember learning about called teardrop fractures, where I think it was like C1 through 4.
Oh my gosh, I haven't thought about those in
I know,
forever.
but like the way our vertebrae are structured, that if you have that compression on the top, it can actually break your vertebrae in such a way that it doesn't affect the spinal cord necessarily yet. But what will happen is you have this free floating little, for lack of a better term, spear in your spinal cord, and as that moseys around, or if you start moving around, you can definitely start having some deep damage off of that one.
I think that's one thing that's important to point out too, right? Like why people can say I broke my back, but they're fine and don't have any neurological deficits. There's a difference between breaking the vertebrae and breaking like the bones and having a spinal cord injury. Those are very different things. So it's important for us to make sure that we're thinking to differentiate those things, that you can fracture vertebrae. I have a good story I'll bring up later too. You can have fractured vertebrae without a spinal cord injury, and really both ways too. So it's important to kind of separate those.
I actually have a story on this right now with a compression fracture. So it was a automobile wreck, MVC, up by a local reservoir here. A guy was ejected from the back seat windows, side windows. When I showed up, we're out of radio range, out of cell service, no internet, which will play a role later in the story. So I get there and I'm talking to the driver. I'm like, well, where's the guy who was ejected? Because that usually is the person everyone's looking at pretty quick. And he's like, I don't know. He's walking around here somewhere. It's like, excuse me, what?
What a terrible combination of words.
Yeah. So he walks up to me, Russian speaking only. I can fiddle my way through a couple of languages. Russian ain't one of them. And yeah, so the whole time I'm trying to get a collar on this guy and he's fighting me. And I had a student with me too. So like, as soon as we get to cell service, I'm like, look up what he's saying. And he's like, I want a cup of water. It's like, he's been fighting me for the last half hour.
I would want a cup of water too.
I believe it, but
I know what area you're talking about is hot up there.
You know the rules, no water.
I know, yeah.
Right?
Last oral intake should be nothing that happens in your presence.
Pre-us.
Yeah,
Yes.
for sure. Well, we get there, we drop them off. Happy feel goods, whatever. Students like, I learned so much. Like, yeah, me too. Let's go. So we moved on to the next thing, and we come back later, and the same guy comes walking around the corner, and he's like, bathroom. It's like, oh, now you speak English, huh? So I directed him towards the bathroom that patients were allowed to use, and then as soon as he walked the corner, a nurse came running around another corner. She's like, where's that guy you dropped off? I was like, oh, bathroom. Why? She's like, he has a C2 fracture. Oof. He had fractured his cervical spine and had been walking around the whole time. No spinal cord deficit, but vertebral body fracture, right? But that's a ticking time bomb, and he
no
is
spinal
so
cord
lucky.
injury yet.
Exactly.
See, that I was going to bring it up because I have for all of you anatomy nerds out there, I have a grade 2 anterior spondylolisthesis caused by a pars defect. And where that comes in is, I know, hear me out.
It's a lot of words.
Yeah, if you're not
That's
watching.
not real.
There's going to be some like EMT student out there who like went to chiropractor school or like physical therapy school who's making a career change. And they're going to be like, I know what that is. I'm talking to you. You know what this is. So it's hard to describe if you're not looking at it, but you have your vertebral body, right? You've got two bones that connect your vertebral body to your spinous processes. So there's the two bones that come out the side and the one in the middle. Those two bones at L5 for me are broken. So my L5 is where this is happening, is not attached to the rest of my spine. So my pelvis is tilting forward, but the rest of my spine is staying kind of, hopefully, in place. But it's interesting because my pelvis is falling forward, which is putting strain on my nerves. And so what's probably going to happen is the treatment for me, even though I don't have a spinal cord injury, I don't have anything to protect me. So if I go get in a car accident, there's the chance that I could walk out of it with a spinal cord injury. So if you work in this area, there's a piece of my medical history that everyone can know. I have a pretty significant lower back fracture. But it's stuff like that. Like I get nerve symptoms every now and then, but it's like sciatica. And a lot of people don't realize that that's exactly what we're talking about, because sciatica is nerve root pain. And your spinal cord injury patients might present with something that looks like sciatica.
Sciatic pain, yeah, because that nerve runs down your, fun fact, runs through your butt cheek. And there's a big, well, that's actually not the right direct description. There's a skinny little muscle called the piriformis in your butt that runs right over the top. And that is a real bugger. If you're someone who's like, man, I'm having lower back pain. And you're like, I don't have a history of
Kylie's thing.
Yeah,
Yeah,
mine's very specific. So most of you probably have a piriformis problem.
Do you have a fused coccyx? I just learned that's a thing. So
I do not.
Oh, see,
it's
that's
certain
how she
areas.
knew.
It's certain areas.
Figuring it out.
One spot. Anyways, I just wanted to bring that up just because it adds to, like, if you're looking at medical versus trauma, even just those kinds of things. So it's just
well, and that
full
actually
circle.
segues really nicely into hyperflexion or over extension injuries. Like, so if she's got that issue where she's kind of tilting, she's already halfway there with the extension. She doesn't want to overdo, right? So if think about it, like I said earlier, our spinal cord is very, very finicky. It does not take much to do damage. we're not we're not fragile beings entirely. Don't let that get it twisted. But that is a fragile portion of our body.
Don't get it twisted.
Yeah, heyo. Yeah, because you'll paralyze. Get
it? That comes next. That's rotation.
Yeah,
I was gonna say that's actually me. I'm the weak one.
Yeah, but I mean, so like think about it. Like I was saying, those jelly donuts, right? So if we have jelly donuts sitting between two rocks, if I push on one side or the other too much, and that's front to back for us, right, towards the bending at the waist or bending back at the lower back, you can overdo and start pushing that jelly donut one way or the other. And when we say a slip disc, that tends to be what it is. Yeah,
and then also going to be causing some damage to the connective tissue as well if we have that hyperextension too.
Right. Yeah. Just remember, any sort of structural injury is not like, this is going to be a kind of step away, but the same thing is like, oh, I sprained my ankle, right? Or I broke my ankle. Just because you broke the bone doesn't mean everything else got away scot-free, right? It's the same thing. If you have an overextension or a hyperflexion type injury, there's ligament involvement, there's bone involvement. You can have those two, the bumps on the back of the spine, those round processes, like you're saying, butt up against each other. Those can fracture. It really just depends. And even, moving into rotation flexion, just any extremes of motion, we're not great at, unless it's something which, hopefully you guys are out there working on rotation, keeping your core strong, because once again, lower back injuries are the number one killer of this job. But keep your lower back strong, and those rotation flexion, just be careful. It's, a lot of this is like someone drops something, they're looking in their back seat, look up, there's the tree, right? They're already in a twisted motion. They're halfway to paralyzed, unfortunately, from the jump. Assumptively. There are weird things happen, but yeah, we can overdo it. If we're extreme on any movement type, we can put our spine in danger.
And it's important to remember too that hyperextension and hyperflexion, it totally depends on where you're at with the segment of the spine. Overextension or like hyperextension and hyperflexion in the thoracic spine look completely than it does in the lumbar spine, and that all has to do with the curve. You have to have that curve to maintain the right amount of tension with the spinal cord. If you decrease the curve too much, like can happen in the what's it called? The stretch. I mean, it's like an old torture device, right? They used to rip you apart or whatever.
The pulling rack.
Yeah, like you think about that, whatever force it might be happening on the large scale, like those are all things to think about. Like hyperflexion of the lumbar spine looks different than the thoracic spine. So get used to that. Think like, oh, it's normal for my thoracic spine to do this, which is flexion, this is extension. Like that'll help, I think, as far as making a little more sense as to why people have injuries in certain areas with the injury pattern.
Yeah, and then keep in mind too, like some demographics are predisposed to some of this flexion, like older folks with kyphosis, where they're, which frankly, everybody nowadays is working their way towards kyphosis without looking down at their cell phone.
Turning into the Wally people.
Yeah, yeah. I got an inappropriate joke that I'm not talking about later. But and then same thing, it was like lordosis, they're overbent on the back. So just remember too, it's a patient comfort thing from a management perspective. We don't want them getting more hurt, and part of that is just going to be dealing with what they have and how can we make this work for us. And a lot of it's padding, blankets, towels, pillows. I know pillows can be hard to come by, but for sure towels and blankets you should have access to. And then as far as other injury patterns go, obviously, you can have direct trauma. Getting hit directly to the spine is going to influence some things. I feel like that one's pretty straightforward. But as far as, you kind of mentioned, you can damage your vertebral body and not the spinal cord, and vice versa. That's where, like if we have a rotational injury, that could be a situation where it's like, oh, well, the spinal cord's damaged, but the vertebral body is okay. I had a patient who, this was a car accident, but this guy was hit. It was an auto-ped, but this guy was hit by a car. When we showed up, he had no step-offs, nothing in his neck, and that's just at least physical signs, at least to his neck. His face was pretty screwed up. His nose was mushy, so BVM was tough to hold. But when we got on scene, it was one of those, like, I saw his hat, and then 25 yards down the road were his boots, and then another 25 yard down the road was this guy. So he got hit going probably 55, 60. He ended up having an internal decapitation, right? So, like, there's that phrenic nerve separation right there, and that was one of those where it's like, as much as we knew there was going to be physical damage, it was odd to me that not feeling that step off or any sort of decap BTLS stuff, but knowing that it's like, oh, well, this is why we have to tube him, and it really opened up. I also saw a medic get a really impressive tube on that, and it changed a little bit of my perspective of that guy. But that's neither here nor there.
Interesting.
Yeah, that's all I gotta say about that.
Yeah, right on. let's hop right into kind of signs and symptoms of spinal injuries then. So when we're talking about this, it's always important for us because we don't know, right? We don't have x-ray machines. We don't have anything like that. So if we have a unresponsive trauma patient, we always need to operate under the assumption that that patient has a spinal injury because we can't know. So until it's proven otherwise in a traumatic injury, we are going to assume that a patient has a spinal injury. Just keep that in mind when we're talking about this, especially like any high level mechanism. Just if they can't tell you that everything's good, just assume it's not. And we're going to take those precautions with C-collars and all that stuff, right?
That's exactly what I was going to say. Read your mechanism, right?
Yeah.
Like if you're dispatched, like, oh, you're dispatched to an ejection from a vehicle, you should already have a half suspicion. Treat for shock, C-spine precautions from the get-go.
Yeah, the first person up to that patient should be going right to hold manual stabilization. It just do that, and then maybe you'll find out later that you don't need to. But right off the bat, just treat it as if it is there until it's proven otherwise.
Rather do it not needed than needed not do it.
Yeah, exactly. So other signs and symptoms, obviously the just pain at the neck or the spine, right? Whether that be just while they're sitting still or upon movement, or have you guys seen the video, the mechanism of injury video? It's like an old like cartoon. Where like the helicopter flies in
It's
and
like an animated on like a highway.
Yeah,
I think you showed this to me in EMT school.
I probably did.
You should send that to me.
Okay, I'll send it to you, and I should be able to screen. If you can write down, we can put this we can link it. I'm sure it's still on YouTube. It's hilarious, but they talk about the poke the spine test. And she didn't pass the poke the spine test. So that's something we're gonna do, right? Like even if they don't have any pain, we're gonna go feel down that spine. Ask if there's any pain as we're palpating the spine, because that's going to also be a sign of a possible injury to the spine. So and that's an easy thing. We can start kind of top to bottom, right? Start at the cervical and just work your way all the way down. If they are supine when you find them, we'll probably have to roll them at some point. Once they're up, just feel the spine at that point. We're feeling for not just for step offs and all that, but for a pain response from the patient when we're doing that.
Yeah, and you'll talk about it, but even lack of pain is something.
Yeah, that's a big one.
So working down, also neurological deficit to extremities is going to be an indication of a possible spinal injury. And it's important to remember too that, like we talked about, you can have spinal cord injuries without injuries to the spinous process or any of the bones, and you can have that the other way around as well. So in these spinal injuries, it doesn't necessarily mean it's like a severed spinal cord. We can have swelling in that spinal canal. I think
It's super common.
Yeah, I think it was Paul Espargaro, who's like a high-level MotoGP racer who I think he didn't have the ability to use his legs for a couple months after a crash, and the swelling went down, and he's still racing, right? So that can happen. So there might be some swelling. Either way, we're going to treat it the same, but look for that, and it can be something as simple as just some numbness or tingling in one of the extremities.
What's a good way to check for that sensation? Do you have any methods?
I mean, ask for it, and then maybe kind of like, tickle the foot a little bit, or like a pin at the bottom of the foot, like that little Babinski reflex, just to see if there's any response.
The one I was thinking is there was, I never had to do this one that I can think of off the top of my head. I've checked it similarly, but like you're saying, touching the foot is kind of telling. Like I had one gal who's concussed, and she's like, I can't feel my feet, and she's anxiety, and I was like, okay, and so tickled her foot, and she's like, oh, stop, that tickles. Like, what? There you go.
That's a great sign. Tickling in my mind is the same thing as a painful stimulus.
It's the same receptors.
Yes.
Fun facts.
I did learn that. But also because you'll do stuff. People can fight through pain. I tell my students this all the time. I'm like, I can easily sit through a sternal rub. You tickle me, or is it like, not only are you probably going to get punched, which I think is really unfair, because then I go to prison and I'm a felon, and but yeah, right. But I mean, like, it is reasonable. So anyways, that's just a funny
But
rule.
you can take a pen, you can take what's the word, catheter from an IV, right? Don't use the needle. Don't need to sharps hurt people.
I mean, that was an old school thing.
I was gonna say that's what I
not
heard
anymore.
people do.
Yeah.
But you drag up, right? And if they're like, I can't feel that. Once you find that line of sensation, Sharpie, mark it, right? And that's when every time you do a recheck, every 5 minutes for unstable patient, double check it, because that sensation line can change, but that's just something, kind of just tool in your toolbox.
I like using just a pen, because this is just what I always had. So if you work in like a clinic or anything, you might see, I can't remember what it's called, but it's used to check dermatomes, like we were talking about. It's this little wheel, and it's got little spokes on it. They're not sharp. I can't remember what it's
Is it
called.
like bakers or something would use?
It's the
sewing
same
machine
kind
or
of thing.
so, like,
Yeah, neurologists
seamstresses?
use them all the time, but it's just got the little spokes, and
Mm-hmm.
it's painless. However, if someone does have like nerve sensitivity or something like that, it might be particularly sensitive. You can create the same thing, and so if you're doing that, let's say I want to check this, I just take my pen and scrape along that spot. It does need to be in an organized manner because that's how these work. But then you compare. So you can do the same thing without that tool. You just use your pen. And that's what I did in the ambulance all the time because I did dermatomes tests because I was comfortable with that. If you're not comfortable with it, it's not going to make sense. But that's where the nerves come in, like we were talking about and all that. So
Line of sensation.
yeah,
Yeah, that's why, and this is why we talk about CMS all the time, right?
Right.
We're looking for circulation and motor and sensory because they're pairs of nerves. So we need to be checking both sides of things. So motor and sensory.
yep.
Working down, we talked about it a little bit before, but especially those high cervical injuries, you could have that respiratory distress or failure based off of that cervical injury. So that's something else we need to be looking for. And then neurogenic shock. So I know me personally, this was one that just did, because it's so different than the other types of shock
Right.
and how it presents. This one was a little bit confusing for me initially. So
Do you guys call it like hot shock, or you remember how we were talking
Hot
about
shock or
that, the
cold
red
shock,
shock or whatever?
yeah.
Were you guys taught that neurogenic is included in that?
No, that wasn't something I had heard.
Oh.
I hadn't even heard.
It
those
makes
terms
sense. I
recently.
just haven't. I mean, I haven't assigned it to that one in my mind.
That's what I was taught. It might be something you've heard before. Just so you know.
I've heard hot shock. We were talking about hot shock, cold shock. I just neurogenic. I can't
Neurogenic
place
is
that one.
probably what you'll hear in there. Just so you know. But anyways,
So yeah, if we're thinking about neurogenic shock, right, we need to think about essentially the brain and the pathway down to the rest of the body, and the brain being able to tell the rest of the body what to do, right? So if there's a disruption in the spinal cord, then the rest of the body isn't getting that signal from the brain anymore. So if we think about what's going on there, right, we have the veins in the arteries, right, and they have the tunica media that has muscles that cause it to scrunch closed, right? So if we think about the resting state of our vasculature, it's wide open. It's those muscles that cramp it down to tighten it down, right? So if that signal is coming from the brain that tells those veins and arteries to be smaller, if that signal is disrupted, then they're just going to blow wide open, right? And so that's one of the things that happens in neurogenic shock, that disruption of the signal makes those veins pop wide open, right? So if we think about our perfusion triangle and how we compensate, maybe you're thinking like, okay, well then the heart rate's going to go up to manage that. If we have that disruption as well with the vagus nerve, then that's not going to really work with the heart because the heart can't be sped up because that there's that disruption there. So this is going to look really different than most types of shock because they're not going to be tachycardic like we would normally see because of that spinal disruption. And they're not going to be, at least initially, they're not going to be pale and cool like we typically see because they have this widespread vasodilation, which causes, blood more to the surface. And so they're going to be flushed and warm. So we're going to have a patient who typically have a low blood pressure, but they're going to be flushed and warm, and they're going to have a low heart rate. Can be harder to pick out because we're looking for those normal signs, right? We're looking for the pale, cool skins. We're looking for tachycardia. We're looking for those normal early signs of shock, and those are not going to be present for these patients with neurogenic shock. So it can be kind of hard to track and to look for if you don't know what you're really looking for, right? So make sure that you're thinking about that with these patients. If you have a patient who's complaining of neck pain or was in this traumatic injury that maybe they had some neck involvement, look for these signs to kind of put those pieces together because it's a little bit different.
Yeah. If you're having a hard time conceptualizing this, just think about the spinal cord as like wiring, right? The electrical wiring. And then it would make sense, right? If we snip wiring, the electronics not going to work one way or the other. We're cutting off communication. It's the same concept, especially with the electricity we use as our method of messaging.
I do just want to remind people too that presentation that Chris was just talking about is isolated for spinal cord injuries. If you do see someone that is a spinal cord and a head injury patient, the presentation that you see, if anytime there's head injury or head involvement, is probably going to be the head injury presentation if they get to that point of like the Cushing's triad. You see these two frequently together. So just a reminder that if there is head involvement, which typically is with spinal injuries, you might see not a presentation like what Chris was just saying. It might be your Cushing's triad. Is all just a reminder. So because that can take over, and sometimes people forget about that.
Yeah, that's a bad day for someone if you have all that going on.
Yeah, if you have a head injury and a spinal cord injury, but I mean that makes sense.
Yeah, it's a lot of stuff.
I mean, they live together though.
They do.
It's not impossible.
Yeah, they're roommates. So, can I just add one thing really quick? We're talking about signs and symptoms. I just want to like bring up the priapism sweep thing because I always get asked about it. The priapism sweep, if you're unfamiliar, is like in the setting of spinal cords, males might present with an erection, and if you think about it, feed and breed, which we're talking about the inability in the setting of spinal cord injury patients for their sympathetic nervous system to actually do its job, letting the parasympathetic nervous system take over. And in parasympathetic state, that is when males are able to achieve their priapisms. So that's why you might see males with spinal cord injuries presenting with an erection, is because it's parasympathetic takeover. It's just another thing to add on that why you might see it, but you have to be in that feed and breed parasympathetic state in order to obtain that. So
I describe that as rest and digest. We have very different
feed and breed.
Yeah.
See, I learned rest and digest it was reiterated in medic school as rest and digest, but when I was in EMT school, it was feed and breed.
Yeah, I always heard feed and breed going through EMT and medic school too.
I tell my students both specifically for that fact right there. So like because I say like feed and breed or rest and digest, whatever it is, it is helpful to remember though that you can't, and it makes sense if you think about it, you can't engage in like sexual activity or anything with your GI or sex organs in general if you're running from the saber-toothed tiger. So that's why, like when feed and breed, rest and digest or whatever, that's when you're actually, your sexual capabilities increase. That's the point of your phase or of your development or not development, I guess just your body where you're supposed to be doing that. So that's why you might see that.
The parasympathetic side sounds way more fun.
So
feed,
everyone,
breed,
I
rest,
know
all the good stuff's on
that's
that
what
side.
I tell everyone. I'm like, everyone talks about how fun it is to run. Like running from a saber-toothed tiger sounds horrible to me, but I'm also a woman, so I believe in self-preservation. I don't think men.
I was just thinking, I'm fighting the tiger.
I know.
What do you mean?
Well, I heard you talk about fighting a badger last week, so I'm not. I
stand on that.
Yeah, my standards are a little different, but. Anyways, yeah, that's that. I think that's one of my favorite fun facts personally is that, and also again, it just goes back and reiterates the why we actually do. If you do, I don't do a priapism sweep because for the most part, it's usually something that we're going to identify pretty quickly. If you're actually following the order of events and you're exposing your patients,
could be obvious.
but it should.
You hope for him it is.
You would hope, and that's why I said you should be able to see it. But if not, you're going to figure it out anyways. Because you're cutting their clothes off, because you're getting them trauma naked. So, yeah, I just wanted to add that in.
Well, they have a spinal cord injury. They don't just like you. There's a difference.
Yeah, Jesus.
Yeah, and for students, like, we want to hear you talk about the sweep. That's one thing I get from students all the time. Like, it's a head injury patient. They're like, I don't think checking for priapism is necessary. I'm like, are you sure about that?
It's a whole point
is.
on your assessment.
Yeah.
I mean, and we tell you, we're like verbalize the genitalia and the perineum and then checking the buttocks. But like, I always paid attention to it. Always. If you're doing your rapid, which, nipples to knees kind of thing, if priapism sweep is or even just seeing it is going to be a part of that.
Yeah, we should visualize everything in that situation. Hopping down to treatment of spinal injuries. They're pretty straightforward realistically. So if we have a suspected spinal injury, we're just going to be doing a jaw thrust, right? We're not going to be wrenching on their neck and doing a head tilt chin lift. So just a jaw thrust, which is incredibly effective.
Yes.
There's a cool video online of like a live x-ray of people manipulating the head and the neck and like doing a jaw thrust, and you can see the airway opening. And it's shocking how much more opens with the jaw thrust than even just a head tilt chin lift. So it's very effective.
That's what we're doing when we're intubating people.
Yeah.
We're doing a jaw thrust.
Or if we're doing
That's all we're
if we're doing a good job with our mask seal and we're holding correctly, we're also kind of pulling. I always really push that we pull the face into the mask. We don't push the mask onto the face to do that jaw thrust and open that airway up.
I actually like the jaw thrust better than Craig pressure for intubation.
I do too.
I feel like the view was so much better.
Yeah.
But that's above your guys' scope. But if you like it, look into it.
And then obviously we need to make sure we're assessing for positive pressure ventilation if that's necessary because a patient is not able to breathe for themselves. So take a look for that. We're going to place a C collar if it's indicated. So I like the NSAID mnemonic for indications for C collar, which some of you guys might know, some of you guys might not. It's pretty straightforward. N is going to be neurological deficit. So that's the N in the NSAID. S is going to be spinal pain or tenderness. A is going to be altered level of consciousness. I is intoxication, which kind of goes hand in hand. And then D is distracting injury. So if you have any of those in the presence of a mechanism that would make you think you need, a C collar, that's the time to place it, right? So easy one to run through that should hopefully cover most of your bases when we're talking about whether to place this a C collar on. And then backboarding, I don't want to get too much into here. It's still in National Registry protocols, but most departments, maybe not most, maybe I'm talking out of turn. In the Northwest where we're from, most departments have moved away from backboarding. I think that that's more kind of the progress of where EMS is going in the future is to move away from backboarding as we're starting to see science showing. Yeah, there's starting to be a fair amount of stuff coming out that it might actually be worse for the patient to put them on a hard board and shove them in the ER for 4 hours while they're trying to get comfortable and all that stuff, and it causes pressure sores. And
you guys ever slept on one side for too long? Imagine doing that on a rigid backboard.
Yeah.
And then you can appreciate why we don't do that anymore.
Yeah.
You ever slept on the floor just generally? It sucks.
And that's softer than the backboard.
Hey, I actually really like sleeping on the floor, but that's because I have a bad back.
Yeah, you've got bad back. So
I do just want to step back really quick with the positive pressure ventilations and remind you that part of the reason that we at least start off with positive pressure ventilations on anybody who has had apnea or I hate the word bradypnea, whatever, low respiratory rate. I hate that word. The part of the reason that we at least start off with positive pressure ventilations is to get those alveoli back opened up because people who are apneic or, again, have a low rate for an extended period of time can have issues with their surfactant. So you want to, which remember surfactant keeps those alveoli open by decreasing surface tension. So people, especially like your spinal cord injuries, might need that positive pressure to help with their surfactant, but also to keep those alveoli open and to help with that gas exchange that needs to happen when you take over their airway when they're already lacking one.
Alveolar recruitment.
Yes, I know that's a lot to take in, but positive pressure ventilations initially in the setting of spinal cord injuries or anybody, I guess, that hasn't been breathing or not breathing enough is pretty much always recommended.
Yeah, National Registry says less than 8, more than 28 ventilate.
Yep.
So as much as I personally don't think that's relevant to the real world, because I don't know if you guys have ever tried to ventilate somebody that's breathing 30 times a minute.
It's hard.
It's not going to happen very well.
You're better off coaching them half the time, but that's National Registry, follow that.
Yeah, follow that, National Registry. If you want to pass your exam,
yes,
less than 8, more than 28.
That concept does change when it comes to head injuries, though. Just as a reminder to those of you, the rate that we bag people is a very touchy subject for head injuries. So again, these two go hand in hand in the setting of head injuries.
Yeah, you can definitely you can get people to be real mad and argue about that.
That's me. I'm one of those people. And that's why I'm trying not to talk about it, is because I could complain about this for hours. We could do a whole episode on why I feel the way I do, but we're not going to.
Let's move on then.
Yes, let's move on.
Backboards as indicated by your local protocol. Just make sure you know your local protocols. For National Registry and all that, if you're having questions about this on your National Registry exam, you're going to backboard. So it's not going to be very, typically your National Registry questions won't be like really in depth about any of that stuff. Just you'll have to do backboarding if you have the indication for spinal precautions, right? So just keep that in mind. I do have one quick story I like to throw. I'm going to throw in right here too about putting the C collar on, thankfully. Had a guy, he was like a hardcore, I don't know if you guys have heard Mammal when we're talking about cyclists. Or no, not Mammal, what is it? Yeah, Mammal, middle-aged man in Lycra, right? And one of the
And
hardcore
what?
middle-aged male in Lycra.
In Lycra?
Yeah,
What's
like Lycra
that?
suits, like the
Oh, I'm poor.
the
I don't.
cycling
That hobby is
spandex.
outside of my capabilities. So,
Yeah, I'm
okay.
also not. Never mind. There's probably cyclists watching this. I'm a mountain biker, so I wear normal people
I
clothes.
ride things with engines.
That's also I do that too. That's way more
Yes,
fun,
yes.
way easier.
Yes. Anyways, sorry.
But so he was out there. He's like a road cyclist, and bystanders reported he was coming up to a curb and tried to hop the curb and just didn't quite make it, and his front wheel hit it, and he endoed.
Sick.
So we get there. Fire's on scene first because it's kind of a ways away from any of the ambulance stations. So fire's on scene, and this guy, like he's probably, I don't know, middle age, kind of, early elderly age, right? And he's just standing up and he's just screaming and cussing at everybody, and he's super agitated. And we get out, and my partner, like, we open the door, and he just like pops his head back in, and he's like, "I'll get you set up for intubation." Like, thank you, because it's exactly what he needed. So we get this guy, and we're like trying to put a C-collar on him. He's just fighting us. He won't sit down, right? And he's just fighting us. We finally get him in the back, and he's still just like moving, whatever. And like we're able to like sneak an IV in him. And we like I tried real fast to get the ketamine on board just to sedate him a little bit. So we get ketamine. Everything went smooth, right? We intubated the guy. We were able to get the C-collar on like we were supposed to. All that was all good. Then there was no, other than the altered mental status, like he wasn't complaining about any neck pain. There was nothing found on palpation, anything like that, right? There was nothing to indicate other than he was real pissed off, right? He seemed more head injured than spinal injured at that point. The head injury, like, whatever.
The combative head injuries.
Yeah, exactly. So we come to find out, like we trauma leveled him, obviously. We come to find out later, I don't remember exactly what vertebrae, but he had 3 cervical fractures. And I don't remember which ones they were, but 3 cervical fractures.
Was he in, have you heard, it's something crazy, like, it's like psychosis secondary to like some kind of like spinal cord injuries or something like that. I'll look it up, but I've heard of like, it's something, it's almost kind of like the autonomic dysreflexia or something.
No, I think this was just like bad concussion,
Right, just
like head
combative
injury.
head injury.
Yeah, combative head
Okay.
injury. But that was one of those ones where I was really glad that we we followed the protocols as far as like we need to C-collar this guy as early as possible. And also that was one where very specifically charting about how he was found, the combativeness, how it, C-collars were attempted but was not possible initially until he was sedated, and covering our butts with that kind of stuff, because if something had happened, he very easily, if he would have moved his neck wrong, he might have given himself a high cervical like spinal cord injury that could have, he could have been a paraplegic, right? Yeah. So quadriplegic. So just kind of a crazy, I still remember you guys, I'll tell you who it is later, but that we get out just popping his head and like, "I'll get you set up for intubation." Like, "Thanks, dude. Yeah, I'll go deal with the screaming
I was
guy."
gonna say, was he naked?
No, he was in the Lycra.
Oh, that's right. That's
Yeah,
right.
yeah, he's a cyclist.
That's
so,
right. I was gonna say that's the cherry. That would have been the cherry.
Yeah, well, I mean, that's not uncommon for us to roll
Find
up on
naked
that.
people.
Yeah.
So yeah, moving on from that. I mean, like we said, treatment's really simple. Wade, do you want to cover one other thing too about this, right?
Yeah, helmet removal. A lot of times, depending on the helmet, that's the biggest thing. Another thing to consider is, if you're going to be on a 911 agency, where are we responding? Because if it's going to be something like, oh, we're responding to a potential neck injury at a high school football game, they have people whose whole job is to make sure they have the equipment taken care of. They can get that equipment off for safety purposes, as well as kind of help us, right? Set us up for success. And what I would say is, if you have the luxury of athletic trainers around, utilize them. They're
Yes.
going to know what they're dealing with. That said, I would very seldom see an opportunity where that doesn't happen outside of maybe youth football games. But even then, there's going to be a parent who's got the stuff to take helmets apart. It's a requirement for a lot of things.
Or just the team docs.
Yeah.
Depending on, like, we have a university. And if it's bad enough, the team docs will still call us.
Right.
Like that kind of stuff. So
Right.
you might run into them.
And if you can, where to leave a helmet alone is if you can take the face mask off and you can still manage the airway. The only thing that you got to keep in mind is potential neck injury is a rounded helmet, right? So we don't want their head rolling, securing that helmet in place. A big thing when it comes to like football helmets, they say, is just take the face mask off. If you can BVM from there, secure the head down. So this is where the old, head chocks or taping to the backboard, something to keep that sturdy. Now, let's say we're in a situation where, it's a motorcycle helmet, so it's thicker in the back, and it's one of those where it's holding their head kind of forward, and it's potentially put them at risk. That's where we may have to take this off, right? Or another one is even if that they're comfortable in that, if we can take the face mask off a motorcycle helmet, do that. But a lot of them, like if you think like moto, right, that's pretty locked in face masks. You're not going to be able to. So the first thing you're doing, checking in through the eye, like if it's a slide guard, slide the guard up, make sure you're looking at their face, double check and see, are they breathing? Yes, no, what can I do airway wise? And then from there, okay, now if we can take the helmet off, it's going to almost always be a 2-person skill. Okay, then that's just, and if you have more hands, but the textbook 2-person skill. So the first person is going to be at the head, stabilizing the helmet. The next person will be at the side. They're going to reach one hand underneath, pin the jaw, reach one hand behind the neck, grab the occiput. Okay, as close to that as they can. And from there, it's just going to be slow and coordinated motions. The person who's holding the helmet is going to be sliding that off nice and easy as that person's supporting the head. Now, once the occiput or the back of the head is available, the person on the side is going to cradle the back of the head and the jaw, and that's going to let them segue into that situation. Okay, the helmet's off. Person at the head will now manage manual stabilization, and then from there, let's get our collars going, let's get our backboards rolling, and then we can get going. But that's one of those that's textbook, right? Now in real life, if you've got hands and people who have, you should do it this way because this, or Chris, you've got more moto experience than a lot of people I know, right? You're someone who'd be like, actually the helmet works better if you do this. I don't know, I'm making this up top of my head, but if you understand
Chris
the
is like,
equipment
thank you,
better,
I am very good.
well, I'm going to give him the knowledge.
I ride a lot. I don't know if I'm very good.
Well, I mean, but you know different helmet styles, right?
Yeah.
Like there's an advantage. Use the people whose knowledge is outside of your own, right? We all have hobbies and specialties. Trust them, okay? But yeah, end of the day, helmet removal is going to be a big one, and especially football shoulder pads. If we can get those off as well, it's going to be a big one. A lot of cutting, okay? Mm-hmm. But once again, we don't want to mangle. That's not the right word. Finagle.
Manipulate.
That's the word I wanted.
No
Manipulate
shimmying.
the neck. There we go.
No shimmying the helmet.
But yeah, that's one technique. There's a plethora out there. But as far as the 12th edition textbook goes, that's the one I'd remember for the NREMT.
Yeah, I mean, end of the day, remember if it's impeding airway management or anything of the sort, then we need to remove a helmet. Mm-hmm. If it's not and it's keeping the patient in like a neutral position, then we can leave the helmet. Mm-hmm. Motorcycle helmets specifically, a lot of the higher end helmets, lower end helmets don't tend to have this, but higher end helmets like your Shoeis or Arise will have like little pull tabs. And so you can pull down and it will pop the cheek pads out. So you can pull the cheek pads right out and get your hand in there to help support. So that's something to look for if you have a patient with a motorcycle helmet, that they're going to be, they should be very snug. A motorcycle helmet should be very tight to your head or else it's not going to do a whole lot. So make sure you're looking for those. I'd imagine because there's full face mountain bike helmets that you might see out there that I would imagine are the same thing. They look
just like dirt bike helmets, right?
They do. They're much lighter weight than dirt bike helmets, but they're very similar in how they look. Some of those might actually, it's very common for mountain bike helmets to have a chin bar that can just be removed. So you might be able to just remove a chin bar from a motorcycle or from a mountain bike helmet, where you're not going to really see that on motorcycle helmets. You have modular helmets where the front will slide up, but you can't remove it typically. So, but mountain bike helmets, you might see that if you're on, because we, especially where we live, we see a fair amount of mountain bike injuries.
I was going to say with dirt bikes, unless even like you were saying, there's obviously a few additions, but most, because I ride as well, but dirt bikes exclusively, they have that pointed chin piece for a reason, and the chin strap is going to come underneath it, but that can leave part of their chin under here vulnerable. So just keep that in mind too for any helmeted patient, is that depending on the style of helmet, it might not be intended to actually protect under here like your actual like road helmets might be compared to, they all kind of do, but like dirt bike helmets, like that innate feature might make them more vulnerable here, or the weight of it might make them now a spinal patient or whatever. But On that note, actually, 2 points I want to make. If you do have a helmet that has sustained trauma, especially multiple traumas, you should be throwing it away. And you cannot trust that the patients who are wearing helmets, even though we'd like to, helmets are always, even if it's old, are always going to put you in a better place, I think. But if someone has a helmet on and maybe the helmet looks pretty jacked up, or the patient's not doing well, consider that that helmet might be bad. And maybe they just hit their head with it enough times or whatever, and the helmet cracked. I've seen some fractured helmets before. I'm sure you guys have, and it usually has to do with either a very, very, very significant singular force or multiple lower end, maybe even, mid-level force or impacts. So I always take helmets with me, especially the trauma surgeon always wants, I've never had one be like, oh, great, they brought this. Exactly for that reason, because if you look at the helmet and there's some previous traumas to it, it can give you an indicator of just how good of a helmet it actually was in that moment.
Yeah, they'll want, because we tell the story, we were on the scene, they weren't. So anything that we can bring with us that kind of gives indications that they can look for, they really want those helmets. And if anybody's listening that doesn't know, is like a new motorcycle rider, generally if you drop a motorcycle helmet for more than like 12 inches, you're supposed to replace it. That one time can destroy the integrity of the helmet for further crashes. So
it's the same thing with car seats. If you have a car seat involved in a collision, you should check your whatever, manufacturer stuff, but you should probably be throwing it out after too many.
And if you can't afford it, or like pro tip to give to your patients too, most fire departments and EMS services will have a budget to have car seats that they have expressly for the purpose of giving to patients if they were in a car accident and that family cannot afford a new car seat, because they are not cheap.
And
you're going to find out real soon here, Wade.
Oh, I bought one. They're not cheap.
Yeah, they're very expensive.
A lot of police stations have similar, or police departments have similar resources too, but the state also has funding for that.
So make sure if you have a patient who's in that situation, it's always good to be like, hey, that car seat's no good anymore. Your baby's life is way more important than $100, and if you can't afford the $100, go to your fire service, go to your police department, and they should be able to replace it for you.
Last thing I want to say on helmet removal is that technique I outlined is, once again, NRMT. Double check your protocols. Just make sure if there's something they want you to do explicitly, just know where you work.
And then we're kind of past time already, but one thing I'd already written it down, so I want to talk about it since I took the time to look into it again. This is, from what I could tell, this was not in the EMT textbook that I could find. It's more a paramedic level thing, but it kind of has to do with spinal cord injuries. Not acute spinal cord injuries, but this is going to be a chronic thing later for patients that have a spinal cord injury. So it's something called autonomic dysreflexia. So, and I'm going to be reading my notes more here because it's complicated. Oh, and I'm in paramedic school over 10 years ago. So essentially, this is for patients, normally spinal cord injuries above T6, so above that thoracic 6 there. And so it's going to be when there is some sort of sensory signal coming from below that injury site. And so that thing's happening, right? There's that stimulus below the injury site. And that's going to stimulate a sympathetic response. And so that sympathetic response, that input is going to be trying to go up the spine to the brain, right? And so it's going to get blocked at that break in the spinal cord. And so essentially, without getting too into it, there's a response going below the disruption of the spinal cord and above the disruption of the spinal cord. And those are going to be opposite responses, because there's a sympathetic response happening. The brain tries to respond to that with a parasympathetic response, but that parasympathetic response can't get down to the level it needs to fix the issue, right? So it's going to be kind of a weird thing that we might see with this going on. But what we're going to be looking for, these are going to be patients with a history of a spinal cord injury, like I said, typically above T6. And we're going to see these patients with an increased blood pressure. They're going to be bradycardic, so blood pressure up with heart rate down, which is not what we expect to see.
It's almost like a Cushing's response.
Yeah, a little bit. It's a little, yeah. kind of weird.
Different things, but
yes, but it's the same compensatory mechanism. It's still a bradycardia induced, or it's still a compensatory mechanism that's been induced because of the hypertension. So it's the same thing. It's just not, I guess. I guess there wouldn't be ICP in this case either.
There's no, it's because there's that sympathetic nervous system response, and the body's trying to bring the blood pressure down by bringing the heart rate down, but it can't get there to tell the blood pressure to drop because it still has that.
So it's just a cardiac output thing, the equation. Cardiac output equals heart rate times stroke volume. Stroke volume's up, heart rate can come down.
We're also going to see flushing in the face due to that vasodilation, and then a headache and sweating are common. So you might see those as well. So these are going to be those patients, and then what this is commonly caused by is something with the urinary bladder. It's like 85% of the time, this is caused by either an overfull urinary bladder or an issue with a urinary catheter or something like that causing that noxious stimulus.
Yeah, it's noxious stimulus. I've even heard like belts being on too tight, or like urinary catheter dislodgement, or even like, you know, there's some sort of like seed that fell from a tree and they're sitting on it for prolonged periods of time.
The princess in the pea, or the princess in the pea, right?
Yeah.
That's how it was described to me. It's these quads are basically, if you don't know that story, it's a princess who they place a pea under her mattress because the true princess will know that there's a disruption with the mattress. It's just an old story, but that's exactly what it is. It could be anything. So in the way it was described to me that made sense is, think about all the things that I need to do right now to make myself comfortable. I need to itch my eye. I need to straighten out my back. I need to get my hair off my neck. They can't do that. So then their body gets overwhelmed. And so
it's a noxious stimulus. So just something that's mildly annoying. They can't sense it. They don't know it's there. And two, it's just, it's an irritant essentially.
So there's not really much for us to do. You can sit the patient up a little bit, which might help with that orthostatic reduction in the blood pressure. And then look for a stimulus that we can remove. So look for tight clothing, belts, that kind of thing. But they're going to typically need more longer term treatment at the hospital. So this is a very hyper specific patient population, but just something to be aware of.
I've seen it a couple times, though. You know, it's especially, that's a demographic we see. So just be prepared. And honestly, like, this is a good one because even at the Mediscope, there's not a lot we do for it. Just get them where they got to go, right? But acknowledging and identifying is a huge piece for us, and that makes the doctors' lives easier. Granted, they're probably going to be like, "No, dummy, it's this," and you're going to be like, "I don't know, dog, I'm just trying." But end of the day, if you're trying, they're gonna work with you.
I'm sorry, I had to.
Is that house? Where
that's a house reference. It's sarcoidosis. I can't say that. Sarcoidosis. Lupus or sarcoid, whatever. Hugh Laurie, if you're listening, I love you.
I'm sure
he's a really talented blues pianist. Just so y'all know. Anyways.
All right.
We don't have a corner called Kylie's Music Corner, so.
We'll learn a lot about Kylee today. You guys have anything else? Something that about wraps it up?
Nope.
No, just, pay attention and trust the patient. They're going to know better than you will.
Yeah, cool. Right on. Hopefully this was a good jump into spinal injuries for everybody. Thanks for watching. Thanks for listening. Whatever, go check out the other videos. Like we said, we have some other relevant podcasts already, like the head injuries one. So go check that out, and we will see you guys soon. Thanks.